Using the 5 French grasping forceps to detach, marsolate, and remove endometrial polyps with large implantation base. In case of a big sessile endometrial polyp, using electrosurgery on large surfaces is known to be a risk factor for adhesions, in addition to all the complications related to the use of electricity, including thermal damage to the adjacent endometrium. Hysteroscopic tissue removal systems are an excellent option. However, their high cost makes them less accessible to many colleagues. On the other hand, the 5 mm continuous flow office hysteroscope with the 5 French mechanical instruments are by far the most widespread hysteroscopic equipment, even in developing countries. They offer the advantage of allowing complete and safe surgery without anesthesia nor cervical dilatation. Additionally, they use mechanical energy, thus protecting the adjacent endometrium from thermal damage and have been testified to not cause adhesions nor synechia. In infertile patients, it is always best to prevent these risks. In this video, we recall and demonstrate the hysteroscopic mechanical polypectomy technique using the 5 French grasping forceps even on large endometrial polyps. But first, why the grasping forceps and not the scissors? As a matter of fact, most colleagues today use scissors and not graspers. Yet, a large study revealed that cutting the pedicle with scissors or pulling on it with graspers, both are more likely to leave a part of the polyp space inside the uterus, thus leading to regrowth of the polyp, recurrence. This is why the technique was subsequently modified by Professor Stefano Betocchi. The new modified technique consists of a strong grasp on the base with the jaws of the crocodile forceps and push towards the fundus. Push, not pull. A strong grasp on the base and push towards the fundus. Additionally, this modified technique is not only feasible in small pedunculated polyps, but even in large ones. In this video, we are demonstrating the technique for endometrial polyps with large implantation base using a simple 5 mm continuous flow office hysteroscope and a 5 French grasping forceps. In this postmenopausal patient, we can see 2 large polyps and a cystic atrophy of the rest of the endometrium. The implantation base is relatively large and cannot be detached in one grasp. The width of the internal os is assessed with a grasper. And so the technique consists of a strong grasp of the polyp's base and gently push towards the fundus. Now on a large surface, need is to reposition the grasping forceps as many times as necessary, always at the base of the polyp, and gently push towards the fundus, until the polyp is completely detached from its implantation base. It is very important to do gentle movements. Never push too hard or too fast, otherwise there is a risk of uterine perforation. Slowly, the polyp is progressively detached. We go back to the cavity and remove the small remnant with the same technique. This is the case of a 30-year-old infertile patient with a large endometrial polyp occupying the whole right posterior lateral wall. See the large implantation base of the polyp. Strong grasp of the polyp's base and gently push towards the fundus. Reposition the grasping forceps as many times as necessary, always at the base of the polyp until the polyp is completely detached from its implantation base. Next step is marcellate it and remove it. With the grasping forceps, we continue to close the jaws and pull. This causes the polyp to tear off into smaller fragments. We simply let them out or take them out with a grasper. And here's the final view of a clear cavity empty of remnants. At the end of the procedure, we collect all the fragments and send them to pathology. The last case is about a postmenopausal patient with a large sessile polyp located in the fundus. More challenging as we are already in the fundus. And so, a strong grasp at the base, very gentle push towards the fundus, we reposition the grasper as many times as necessary. Patiently, slowly, very gentle movements when we maneuver at the fundal level. Here we tackle the inferior edge of the large polyp. We keep on patiently until the polyp is completely detached. Although the procedure might take some time, especially marcellation and removal, at the end we have a complete resection of the polyp with no remnants, no dilatation, and no thermal damage to the endometrium. Thank you for your attention.